Clear. Great. Good. Namaste, everyone. My name is Dr. Ramu Karel. I am an assistant professor of emergency medicine. And as you know, we've been working with the Poison Center for the last year now. Really welcome you to this webinar today. This is probably our 9th webinar we have done in the year. So we've been doing it every month. Today, we have really two great speakers who will be talking to us about some of the foundational toxicology material. We'll start with a discussion on general toxidromes, and then we'll go into salicylate poisoning, which both are very important topic. Before we move forward today, I did want to share with you that we have run this Poison Center for a year now. This last month, we had some really exciting activities. We celebrated the first anniversary of our Nepal Poison Information Center. And as you know, this is based at TUTH, and our partners there had a nice celebration. The health minister was there also, showing commitment to the Poison Center. So this is something we know that needs to expand in the country, and that we all need to push towards. So thank you all for your support in joining this capacity building and lectures. We're so happy to see this entire engagement. We're also published last month in Global Health Science and Practice, which is an international global health journal, on how we have established and shown feasibility of this first institutional poison information center in Nepal. So a lot of countries like Bangladesh and Iran and Oman, we have very similar ways of doing this poison center, and there is stuff that we have been learning from each other. Now, before we begin, I just want to highlight this event that's coming up next month. As you know, lead is very big in Nepal. Almost 66% of Nepal children are found to have high level of leads. Next month is the International Lead Poisoning Prevention Week. On October 21st, the Nepal Poison Center, in collaboration with MENATOX, Middle East and North African Clinical Toxicology Association, and the Oman Poison Center will be hosting a joint session on the international stage on lead poisoning. So please be sure to flag this date and register on the WHO website. It's a free event, but we would love to see a lot of participation from Nepal, and we'll make sure to have a flyer out for this as well. So with that, I'm going to ask Grant to share his, I'm going to stop sharing. And Grant, if you can share your lecture, I'm just going to introduce you to the audience. So Dr. Grant Comstock is joining us from Milwaukee, Wisconsin. So he is the assistant director of the Poison Information Center there, Poison Center there, and he's also assistant professor of emergency medicine at the Medical College of Wisconsin. Dr. Comstock resides in a place where I met my wife first, so I'm always a big fan of Milwaukee, and we're very happy that he's joining us with this wonderful lecture to talk to us about general toxidromes, and which I'm sure you will all find very valuable. So, Dr. Grant, the floor is yours.
Awesome. Hey, thanks so much for the introduction, and thanks for having me on this webinar. That's a lot of really exciting stuff you just went through. I'm really honored to be a part of this, and congratulations on the 1-year anniversary. That's all really exciting and cool stuff. So congrats to everybody. Like you said, my name's Grant Comstock. I'm a physician here in Milwaukee, Wisconsin. I am an emergency physician as well as a medical toxicologist, and I work at the Wisconsin Poison Center. And like it was mentioned, I'll be talking to you all today about general toxidromes. A couple of objectives for the talk today. We're going to talk about just the concept of toxidromes. My hope is that you'll understand the features and the value of understanding these major toxidromes. And then I want you also to come away with a generalized approach for how to manage patients who are manifesting features of specific toxidromes. So to begin, what is a toxidrome? It's a portmanteau from the words toxic syndromes. And it's really a group of signs and symptoms that consistently result from a particular class, a toxin or a particular class of toxins. And the reason they're so valuable is oftentimes in toxicology or when we're managing patients from a poison center, we don't know what a patient took, if they are encephalopathic and confused, or they're nonverbal, or for whatever reason, if they're unable to tell you exactly what they took, well, then you can't maybe give a specific antidote, but oftentimes that's okay. And that's it. That's the vast majority of cases that we see in toxicology. And so the goal is to recognize these important deviations from normal vital signs or normal, symptomatology, and say, okay, based on this grouping of symptoms, I have a general understanding of what this person might have taken, and I know how to prioritize their clinical care. So we'll do this in a case-based way where we run through 5 different cases talking about 5 different toxidromes and putting them together into a big chart as we go. So case 1. So we'll start with a 47-year-old male who comes into the emergency department in the custody of police. This person was arrested at a routine traffic stop, and now they are acting erratic. They're aggressive towards the police. And the patient's noted to be thrashing at the restraints on your exam with incoherent speech, but no discernible complaints. The police say they suspect this person ingested a bag of drugs just prior to arrest. We call this stuffing, when a person just stuffs a bunch of different drugs in the effort to conceal that drug away from law enforcement. And have the vital sign abnormalities that you see here. So they are markedly hypertensive. They are markedly tachycardic and tachypnic. You get temperature and you find that they are hyperthermic at 39.6, but they're saturating fine on Romer. And forth, I'm not sure if that will necessarily lend itself well, but does anybody have an initial pharmacologic agent of choice that they would think of for this patient? Would you want to control their blood pressure? Would you want to give them a GABA agonist as a sedative of sorts, an antipsychotic? Would you want to manage that temperature with an antipyretic? Or would you say, no, I need some more definitive diagnostic information, so I'll wait for the drug screen to result? And maybe in the sake of time, we'll move forward. And I'd say there's a clear answer. There's maybe a couple of reasonable answers on here between the GABA agonists and the antipsychotics. Oh, I see some chat activity. GABA, lovely.
We have Natalia saying GABA agonist.
Perfect. You're all over it.
We have some people saying controlling the BP.
Okay. All right. Perfect. Yep. Fair enough. So let's talk it through. So as far as what we're looking at right now, the case was really meant to reflect either cocaine or an amphetamine or a stimulant of some sorts to produce what we call a sympathomimetic toxidrome. And the way this works, so this diagram specifically is referring to cocaine, where cocaine will block the reuptake of things like dopamine and norepinephrine up into the presynaptic terminal. And so you have increased concentrations of the catecholamines, dopamine, epinephrine, norepinephrine, serotonin, all sitting here in this synaptic terminal. And so it leads to that sympathomimetic or that sympathetic surge that you can see. And the same is true for amphetamines and other stimulants, where you have increases in those endogenous catecholamines in your synaptic cleft. What this ultimately looks like is this constellation of different signs and symptoms. And so for cocaine, for amphetamines, what you'll see is patients will have a lot of those fight or flight type of manifestations where their pupils will be big, their skin will be wet, their vital signs will be notable for elevation in blood pressure, in their heart rate, and they'll be breathing fast. And I'll say this may or may not be the case, where you may see some increase in bowel sounds or bowel activity as well. In general, from an appearance standpoint, they'll also often be maybe aggressive, they'll be thrashing, perhaps delirious to go along with all of this. And the one abnormality that I really want to point all of your attention to is the abnormalities that you'll see with their temperature. We know it from a number of clinical studies, of animal studies, that when patients are exposed to cocaine for amphetamines, that the thing that really drives their mortality in these scenarios is abnormalities in their temperature. So yes, their heart rate will be high. Yes, their blood pressure will be high. That's actually generally quite well tolerated. And so I certainly would not be reaching to anything to control the blood pressure or the heart rate right away. But if I see that their temperature is high, I've got an immediate red flag to say this is a really sick individual and they need really aggressive, immediate, supportive and life-saving care. And so how do we treat somebody who comes in with a sympathomimetic toxidrome? Well, the answer is GABA. And the reason is when we agonize the GABA receptor, this is that receptor that sits on the postsynaptic terminus, we then hyperpolarize that postsynaptic terminal. And even though you have maybe increases in amounts of norepinephrine and epinephrine and dopamine, If you're agonizing GABA, you maybe increase or decrease the responsiveness of that postsynaptic terminal to all of those catecholamines. And so it just cools the brain off, turns the brain off, and makes it less sensitized to all of those catecholamines that are increased in the setting of a sympathomimetic. So we start with, we want to treat the agitation. We want to treat seizure if it's present, which can certainly be the case in the setting of cocaine or amphetamines. I've offered a couple of dosing recommendations of how I start. Diazepam is my preferred agent for the control of acute agitation from a sympathomimetic, but midazolam is also quite reasonable. I prefer these two benzodiazepines, particularly because they're fast in acting. They're the quickest onset as far as the benzodiazepines that are out there. And so I prefer them to lorazepam. But frankly, if you have lorazepam available and that's the only thing you've got available, fine. But whatever you do, you want to be giving them a lot of GABAergic agent right away. And the other thing to think about is, I've offered a couple of dosing recommendations, but the dose that they need is the dose that they need. And so if 5 milligrams of diazepam is not enough for this patient, fine, give them more. If they're still hypertensive, if they're still thrashing away, if they're still hyperthermic after 10 or 15 or 20 of diazepam, it's because you haven't given enough diazepam. And so you continue to give more of that agent. And ultimately, if patients are showing you that they are refractory to what seem like some pretty aggressive doses of diazepam, oftentimes what I'll say on the line with the treating physician when I'm the poison center doc is I say, look, if you need to intubate this patient in order to control their agitation, in order to improve their hyperthermia, then you need to intubate them, and that's okay. So deep sedation with things like propofol or other kind of deep sedative hypnotics is a very reasonable thing to do for these very sick sympathomimetic patients. For the hyperthermia, again, of all of the vital sign abnormalities, I really like, this is a big red flag. You have to treat that hyperthermia, and it has to be controlled, because the thing that controls or leads to severe morbidity or mortality in these patients is uncontrolled hyperthermia. And so you want to start by doing the same things. You start by treating hyperthermia with aggressive sedation, the way we've described above. But for those patients who come in and they're already hyperthermic, at the same time, I'm also cooling them externally. That can be things like evaporative cooling with misting fans and things like that. But we'll also occasionally do things like submersion in things like ice baths and things like that. Of course, you want to make sure they've got a protected airway if you're doing that. But rapid control of hyperthermia is absolutely of paramount importance in these patients. And then for the other side, vital sign abnormalities, I'll say for 95% of these cases, even the ones who are quite sick, even a patient like this, it's quite uncommon to need to give them an antihypertensive at all. The hypertension is not primary hypertension in the way that you may have somebody who comes in with a hypertensive emergency. It's driven by that sympathomimetic. So you want to treat the sympathomimetic toxicity by giving them that GABAergic agent, aggressive diazepam, aggressive midazolam, whatever you've got. Sedate them with, propofol or whatever it is, intubate them if you need, but you need to kind of sedate them. And then oftentimes, the vast majority of the time, their blood pressure will follow suit. If they are, for whatever reason, persistently quite hypertensive, then fair enough, you may need to control their blood pressure with other means. A general rule of thumb is that we try to avoid things like beta blockers. This gets into far more of a niche and nuanced consideration. But if you have a patient who's got a massive cocaine overdose and you give them a beta blocker, there's some concern that you'll leave them with some unopposed alpha agonism. They'll wind up having vasospasm in the peripheral vasculature, and it can lead to actually maybe potentially worsening perfusion in the peripheral vascular beds. And so thinking about things like calcium channel blockers or nitroglycerin would probably be the way that I would start if you so needed to control their blood pressure. But to start us off, we'll say for the sympathomimetics, they'll have hypertension, tachycardia, they'll be hot, they'll have the big pupils, they will have wet skin, and they'll have this hyperactive delirium. And that's the way you can think about these folks. Let's move on to the next. So case 2. And I know I'm moving relatively fast. I've got a fair amount of material for a short time frame, but please feel free to interrupt. I'm not monitoring the chat well, but Dr. Carell, please stop me if I'm having questions or things like that.
Will do. Thank you.
So for case 2, we'll start with a 21-year-old male who comes in with confusion, quote unquote, saying some bizarre stuff for the last hour. He had one episode of emesis that they note is pink in color, but no blood. And a family friend informed them that he may be using Benadryl to, quote unquote, get high. So this is kind of the scenario where you may not need the Toxidrome because you've maybe got an exposure that you already know. But now that we have this exposure that we know, we kind of have some expectations of what we're thinking we're going to see for this patient. And so I asked the question, which of these does not fit with the expected clinical picture? Is it tachycardia? Is it mydriasis, so dilated pupils? Is it elevation in temperature or hyperthermia? Is it diaphoresis? Or is it urinary retention? I know it loaded up into the chat last time, so I'll give a couple of seconds. There they come.
We're hearing D right
D.
now.
Yep, lovely. Yeah, so agreed. D would be the answer. And we'll talk about why here momentarily. So when we talk about Benadryl, we're talking diphenhydramine. Diphenhydramine has multiple ways in which can cause toxicity, but for the point of this lecture, what we're talking about is the anti-muscarinic features of diphenhydramine. Oftentimes, you'll hear the word anticholinergic. I prefer the term anti-muscarinic because when we talk about anticholinergic, we're talking about the activity of all acetylcholine. This diagram kind of breaks down where acetylcholine acts in the body at large. And you can see we act primarily here on the parasympathetic side. And when we talk about the parasympathetic side, what we're talking about is the activity of acetylcholine on muscarinic acetylcholine receptors. And what that muscarinic receptor is doing when it's bound by acetylcholine is it's producing that rest and digest parasympathetic picture. So when patients have a lot of acetylcholine bound to their muscarinic receptor, they'll have things like maybe some CNS depression or some confusion. You'll see things like small pupils. They'll be wet. So I think about them being quite leaky. So lacrimation, salivation, a lot of secretions into the lungs, bronchospasm, etc. They'll also have a lot of GI motility. And so they may have some diarrhea, things like that, but that rest and digest picture. The nicotinic component of this is what's acting at the neuromuscular junction. And when we talk about antimuscarinic agents, they are not acting there. These are not paralytics. They're acting specifically on the muscarinic acetylcholine receptors. So the better term for this really is antimuscarinic. And so this is what acetylcholine is doing at a muscarinic receptor. What happens when we block that receptor and we have an antimuscarinic toxidrome? Well, we look something like this. This is the anticholinergic or antimuscarinic toxidrome. And this is shamelessly stolen from the internet from a lot of different places that you can see. But what you'll find is these kind of classic pictures, these classic describers, where patients will be mad as a hatter or confused. They'll be blind as a bat because they'll be very mydriatic. They'll have big dilated pupils. They'll be red as a beet with that flushed skin. That's because they can't sweat because of those skin muscarinic receptors are being blocked. From their vital sign perspective, they'll have tachycardia, maybe some elevation in their blood pressure, although not nearly as much with the sympathomimetic. And they'll be hyperthermic because they can't dissipate heat because, again, you're blocking the ability to dissipate heat through sweat glands. They'll have really dry mucous membranes. And then with that delirium that you see, it's very different from the sympathomimetic, where sympathomimetic, anecdotally, they're quite aggressive oftentimes, versus an antimuscarinic. They're often quite confused, they're delirious, they're grabbing at things, but they lack that overt aggressive kind of picture. And then the last one to not forget is the change in bowel and bladder activity, where they'll have decreased bowel activity, decreased bladder activity, so they can have significant amounts of urinary retention as well. Keep in mind, this antimuscarinic presentation can come from a lot of different agents. It's not just one class. We talked about Benadryl, but don't forget antipsychotics that commonly have it. TCA antidepressants. Bentyl is a antimuscarinic that's used to decrease bowel spasm, and then Flexeril here on the far right, commonly used to decrease muscle spasm and things like that, commonly referred to as a muscle relaxer. So you can see this presentation from a broad array of different agents. The treatment for patients who come in with this, again, it's primarily supportive. We talk about that management of agitation. It's usually through benzodiazepines, and frankly, often it's benzodiazepines alone. However, for the delirium, the most effective agent and what I'd say is the quote unquote antidote of antimuscarinic delirium is things like physostigmine and rivastigmine. These work by increasing the amount of acetylcholine present in that synapse, and therefore can overcome that blockade to some degree. However, this is limited by a couple of reasons. One is just straight up availability. Even here in the United States, we frequently don't have this. It's on shortage. The manufacturer recently that was present here in the U.S. Stopped making this because they went out of business. And so availability is often a limiting factor, but it's also often very short acting. And so it doesn't have long-term resolution in your symptoms. And so for the majority of these patients, what you're going to do is just control that agitation, control those vital sign derivations, just through the use of benzodiazepines as needed. And then the rest of this is you give them fluids if they're dry, you give them cooling if they're hot. And then don't forget about that degree of urinary retention that you can see, which can often drive at least a portion of their delirium. And so if they're retaining a lot of urine, you want to make sure you decompress the bladder with a catheterization. And so again, a very similar clinical picture. What I'll say is really the differentiator between this and sympathomimetic. Don't forget the skin changes are the big one. And so they'll be quite dry for antimuscarinic. And their hyperactive delirium looks very different, less aggressive, more confused, and almost like a curious and kind of scared type of picture. And so some more subtle differences in that regard. But the skin is the big driver of the difference between these two. So cases 3 and 4 we'll do is a bit of a pairing because they're commonly confused and mistaken for each other. So we'll talk about them as a pair. So case 3, this is a 62-year-old woman who comes in, brought in by family members who are concerned about her having some difficulty walking. She's confused and she's sweating. And all she's able to tell you is that, quote unquote, it hurts, but otherwise has no specific complaints. You get a bit of medical history. You find that she has a history of schizophrenia, as well as hypertension and hyperlipidemia. And most notably on this medication list is her aripiprazole, a second-generation antipsychotic. On her exam, you find her to be quite hypertensive. She's a little tachycardic and a little tachypnic, is also hyperthermic. On exam, she's awake, she's not oriented. And you find that as though she has symmetric cranial nerves, she's not moving any of her 4 extremities spontaneously. And I think the link dropped off, and I apologize. But the other finding is that she's got rigidity. You try to move her limbs, uppers and lowers, and you find her to be quite rigid, difficult to flex at any of her large joints. So we'll pause on case 3 and we'll go to case 4. And we're going to loop these all in together. Case 4 is a 23-year-old male who's coming in from a nightclub, comes in with friends. He's agitated, tremulous. Friends say maybe there was a seizure. Friends say that maybe this patient was using ecstasy, and so we have a possible exposure, but there's no other discernible complaints from the patient. He has a past medical history that's notable for anxiety and depression, and quite notably, he's on fluoxetine for the treatment of those 2 diagnoses. On his exam, also hypertensive, also tachycardic, also tachypnic, and also hyperthermic. He's awake but not oriented, and he's thrashing. So as opposed to the prior patient, he is very hypermobile. He's diaphoretic, he's mydriatic, and he is grossly tremulous. And so I bring these 2 as a pair because they bring up the case 3 is talking about the diagnosis of NMS or neuroleptic malignant syndrome. Case 4 is talking about the diagnosis of serotonin syndrome or serotonin toxicity. And I bring them together is because if you look at them as a clump, you can very kind of superficially see them as this triad of abnormalities where you see elevation in temperature, change in mental status, and these neuromuscular abnormalities, either hypermobile or hypokinetic. And so oftentimes they get mistaken. You say, hey, it's the same combination of things. But my plug for you today is to say that these are not similar presentations. They're fairly easily differentiated. And I want to kind of highlight those differences between the 2. So let's talk about NMS first. The way that this happens is you block dopamine. This is not necessarily in the setting of acute overdose. This can happen during initiation of an antipsychotic or an antidopaminergic agent. It can happen during the dose adjustment of a dose or of an antipsychotic. It can happen from the withdrawal of a dopamine agonist. So if somebody's on carbidopa, levodopa long-term, and all of a sudden they stop taking it, this can occur. Or it can happen idiosyncratically where they're on that medication long-term. But it's not necessarily in the setting of an acute overdose. So a major difference between that and serotonin toxicity. When you block that nigrostriatal dopamine pathway, you get rigidity. When you block the hypothalamic dopamine activity, you get derivations or abnormalities in temperature regulation, so hyperthermia. And when you block the mesolimbic and mesocortical dopamine activities, you can lead to changes in mental status. It's not nearly as well described for NMS as it is for serotonin toxicity, how these patients present. But keep in mind, the major things you're going to see are changes in temperature, usually mild, not marked, but you can certainly see up to 38, 39 Celsius. You're going to see changes in mental status, some degree of waxing and waning confusion. The big one is the neuromuscular abnormalities. And so patients who are stiff or rigid. And then again, that is the main difference I really want to highlight between this and serotonin toxicity. These are going to be patients who are hypokinetic, difficult to move, maybe complaining of muscle aches and muscle stiffness, or you may even see kind of isolated changes in things like creatine kinase. And so if you see rhabdo in an unsuspected kind of setting and they're hypokinetic, you want to be thinking about NMS. But these are kind of the main ways in which it will present. As compared to serotonin toxicity, there are a number of different classes of medications that can lead to serotonin toxicity. But a main point to get across is you don't often see it until you have multiple classes of serotonergic agents that are combined together, leading to elevations in serotonin at the synaptic cleft. So if you have increased release via things like amphetamines or cocaine, if you have a decrease in breakdown via things like monoamine oxidase inhibitors, if you have things like decreased uptake, these are the most common ones that we see, certainly with things like tricyclic antidepressants, SSRIs, SNRIs, et cetera, or even these direct agonists of the 5-HT2 receptors, things like lithium, LSD, the triptans, et cetera. When you combine these classes of medications, like our patient did, who was both using ecstasy or MDMA, which is an amphetamine, as well as he was already on an SSRI, that's a classic case and a classic setup for developing serotonin toxicity. How do these look? Well, this is far more characteristically described. And I apologize for the poor resolution of this. This comes from a New England Journal review of serotonin toxicity, but you're going to see things like increased movement. So patients often will just be restless, fidgety, agitated. But as it progresses up that spectrum of serotonin toxicity, you see the more characteristic manifestations, those neuromuscular changes, where patients have clonus and hyperreflexia. When we talk about clonus, it's that classic picture. You yank back on their foot, you kind of do that jerk, and it goes pat, 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 and it will just continue on. In the patients who are sicker, it can just continue on even in the absence of kind of yanking on their foot. It's what we call spontaneous clonus. You see those changes in vital signs, hyperthermia, hypertension, elevations in heart rate, things like that. And just the way we talked about with cocaine, it's that hyperthermia that drives mortality that we get very nervous about. But again, to highlight the difference between this and NMS, it's that hyperkinesis, not the hypokinesis. So again, to look at these two side by side, the offending agent for serotonin syndrome, it's serotonergic. It comes on often within 24 hours, and often is when you're mixing classes of these medications or in an overdose, and you're going to get that clonus, that hyperreflexia, hyperkinesis. NMS, we're talking antidopaminergic medications or the withdrawal of a dopaminergic medication. The onset far more gradual, comes on over days or weeks, and it's the bradykinesis. And so although that triad is identical, it clinically looks so different. I want to really highlight that these are things that are relatively well differentiated. But if you're confused, which of course still occasionally happens, the good news is the care is quite similar between these two. The initial therapy, you want to stop the thing that's offending. If they need to be back on their dopaminergic medication for NMS, then great, start them back on their medication, but you want to stop the offending agent first. Supportive care, same between the two. You want to sedate them. GABA agonist is the way you start. You can use the same dosing strategy we talked about earlier. If they're quite hyperthermic, you need to cool them off, and you need to cool them off quickly. So we talk about things like aggressive external cooling. If you need to give them cold fluids, great. If you need to give them cold fluids into a Foley, great, do those things. And then for specific antidotes, it's far less common to be doing these things. And I'll say that this is not the mainstay of supportive care and is far more niche when you talk about how to manage these patients. For serotonin syndrome, we talk about serotonin receptor antagonists, so things like cyproheptadine or chlorpromazine. And for NMS or neuroleptic malignant syndrome, we're talking about dopamine agonists, so bromocriptine, amantadine. Dantrolene is not a dopamine agonist, but it does help with that muscular rigidity. And so all of these, in my mind, are very reasonable antidotes if you needed to kind of advance beyond that standard supportive care. And in very refractory cases of NMS, we talk about electrical convulsive therapy, ECT. And so again, kind of highlighting the difference between the two, we've got the rigidity for the NMS, but with all of these other kind of vital sign and clinical manifestation abnormalities. And for serotonin toxicity, it's that hyperreflexia, the hyperkinesis, the clonus that really differentiates it. And Dr. Rameau, please, if I'm going over, please stop me. I don't want to take in any of the next speaker's time. Apologies.
Yeah, we have about 2 minutes,
Okay.
Grant. Sorry.
All right. We'll no, that's okay. We'll make it rapid fire for this last case. So for our last one, it's a 2-year-old male, comes in unresponsive, not waking up from his nap at the usual time. So a concerning story. The parents have a history of opioid use disorder. The patient comes in with a normal for age blood pressure, a normal for age heart rate, but clearly an abnormal respiratory rate, and there's afebrile. On his exam, he's unresponsive. He has no evidence of trauma, but pinpoint pupils. So we have decreased responsiveness, pinpoint pupils, and slow breathing. That triad, as well as the reversibility with naloxone, I want you to think about as the paradigm for opioid toxicity. Doesn't need definitive testing. You don't need a drug test for this. This patient on arrival, you have a diagnosis, but while you see them. And so when you see them, clearly nobody's going to be looking at diagnostic testing. You want to start to reverse this patient's clinical manifestations of opioid toxicity. So a brief overview of opiates versus opioids versus synthetics. Opiates, we talk about the things that come directly from the poppy plant and it has this kind of characteristic classic structure. Semi-synthetic opioids like oxycodone, hydrocodone, hydromorphone, or heroin use that same base structure, but have some permutation of their chemical structure. What you're looking at right here is heroin, where it has these two acetyl groups that are hanging off of the otherwise structure of morphine, which is on the left. And then the synthetic opioids, things like fentanyl and dextromethorphan fentanyl, which is of course causing major problems here in the United States. They will also act at that mu receptor, but have no structural similarity between the opiates or opioids. Apparently my animation didn't work for this, but what is the indication for naloxone for these patients? It was highlighting the point that if they're sleepy, if their pupils are a little small, if their bowels are a little slow, that's no big deal. But the indication for naloxone for opioid overdose is only respiratory insufficiency, which clearly our patient had. Oh, there it goes. Yeah, perfect. And for dosing for naloxone, if they're naive, like a pediatric patient who presumably isn't on it all the time, will commonly recommend starting at 0.1 per milligram per kilogram up to about 2. And if they're opioid tolerant, your goal is to give them the lowest possible dose that you need in order to restore their respiratory drive. And so sometimes for an adult, we'll talk about 0.04 or 0.1 milligrams to start. And the goal being to avoid the precipitation of naloxone precipitated withdrawal. And again, adding that to our table at the end. And of course, I'm happy to share all of these slides with you, but I'll end with that. And I'm happy to take any questions, understanding that I've probably gone over.
Thank you so much, Dr. Comstock. That was really well done, kind of sort of summarizing all this complicated toxidromes within that short time frame. And I think this provides a really good framework of sort of for anyone to refer to. And for everyone, this is also a recorded lecture and it will be on our YouTube as well, but we'll be sharing Dr. Comstock's slides with you as well. If you have questions for him, please type it here. If you don't mind staying a bit longer, if there are any questions to answer in the chat. I am very happy to now introduce our next speaker. Dr. Kazzi, are you here?
Yes, I'm here.
Okay, great. So I think you can share your screen while I introduce you. So Dr. Ziad Kazzi does not really need an introduction for the Nepal Poison Center, as he's very, very well known here. He's a professor of emergency medicine at Emory University. He's also the director of international fellowship in medical toxicology at Emory. He is the assistant director of the Georgia Poison Center. He's the immediate past president of Menatox, as well as he's on the board of directors. He has done a lot of work around the world in establishing Poison Center, doing poisoning research. He focuses on nuclear medicine as well a bit. Dr. Kazzi has been the staunch supporter of our Poison Center and my mentor in many ways in establishing this. So we're so happy to have him join us and give his time to talk to us about salicylate toxicity, which is on the rise in Nepal as well as around the world. So Dr. Kazzi, the floor is yours. Thank you.
Thank you, Dr. Karel. Thank you, everyone from the Nepal Poison Center who's been organizing this. How much time do you want me to do?
I would say 25 minutes if you can, and then we'll have some time for questions.
Okay. All right. So, and remember that we are going to meet again October 21 for a joint webinar. Maybe we can advertise about that at some point, Dr. Karel. But salicylate is so important because it is a common poisoning. I am going to move a bit faster with these slides than I intended to because of the time. So I'm going to try to give you the most important learning points right off the bat. And I may not stick with the slides too much, so I apologize if you see me, not really covering everything on the slide or skipping a slide rapidly. But a classic case that you need to be able to detect in presentations of salicylate poisoning is the vital signs. So look at those vital signs. You are going to have somebody who's a little bit confused, maybe not even clearly confused, maybe a little bit sleepy. You may also find fast heart rate with a rapid respiratory rate. They may tell you they are short of breath. They may look like they are short of breath. But when you examine their lungs, the lungs will be clear. If you do a chest x-ray, the chest x-ray will be clear. I've seen cases of salicylate poisoning where we did a workup for a PE protocol for a pulmonary embolism before we thought about salicylic acid. To remember that. Next, remember that they are very common and can be missed. If you don't check a salicylic acid level, if you have one, then you will miss it. And it's not unusual for this to happen, especially in chronic cases that do not present with a suicidal overdose. And this has been studied where people often are missed, and often a neurologist is consulted before they consult a toxicologist. Salicylic acid is really most famous for aspirin, which is acetyl salicylic acid. It's not the only form of salicylic acid. There's also methyl salicylic acid, which is a kind of a analgesic ointment, oil of wintergreen, that contains methyl salicylic acid. The active components of both aspirin and oil of wintergreen is salicylic acid. It's also present in Pepto-Bismol, which is used to prevent diarrheal illnesses or treat gastroenteritis. And that one is bismuth subsalicylate. So like I said, there are numerous formulations out there. Just keep in mind that the methyl salicylate can be quite toxic for children. 1 milliliter contains 1.7 grams of salicylic acid. So sometimes we see cases where a baby, is rubbed with this, developing severe toxicity. Salicylic acid is great for health because it inhibits prostaglandin formation, inflammatory mediators, by inhibiting cyclooxygenase, which is why we use it. It also inhibits platelet aggregation, which is why it's used for coronary heart disease and ischemic conditions. However, aspirin is metabolized in the body into several acids, like salicylic acid and gentisic acid. It's also metabolized in the liver into glucuronides that are excreted in the bile. An important thing about salicylic acid is that a small amount, only about 3%, is excreted in the kidney. And yet, one of the management strategies in salicylate poisoning is alkalinizing the urine. We alkalinize the urine to increase this percent from 3% to greater than that, and decrease the salicylic acid level in the serum and toxicity from the tissues. Salicylic acid is primarily bound to proteins. However, lucky for us, that's at 10 milligram per deciliter levels. And when people are toxic with salicylic acid, there's not enough albumin to bind it. And that's why you find more of it is free to be dialyzed, because that's the second management strategy in salicylic acid, which is using dialysis. So dialysis and urine are the two strategies that we are going to use. Luckily for us, urine excretion is pH dependent. The greater the pH, the more the excretion. And luckily for us, when you are toxic, you have plenty of salicylic acid that's not bound to albumin that can be dialyzed. And of course, metabolic products will cause acidosis because, as you see, you make acids through metabolism. The other important fact about salicylic acid, that early on, it's going to stimulate the medulla to make people breathe fast. They just breathe fast, okay? And that causes respiratory alkalosis. But shortly after that, after you develop this respiratory alkalosis, you start seeing the acidosis. You start seeing the metabolites. You start seeing those metabolites I just showed you on the previous slides. Salicylic acid itself is an acid. And also it can affect the mitochondria and causes lactic acidosis. So again, all of these are going to explain why people slowly will start developing the metabolic acidosis. And then you will get the picture of mixed respiratory alkalosis and metabolic acidosis. As time goes by, the respiratory alkalosis goes away and you have severe metabolic acidosis. So if somebody does not present to the hospital initially, like a child, an old person, someone who was drunk or took an overdose of benzodiazepines, these people will not show up early on or cannot breathe fast. Those will present rapidly with acidosis. And you miss the whole respiratory alkalosis picture. But a typical ABG in a patient that's coming in the middle phase is going to have a very low PCO2. The pH will be kind of normal, 7.35, 7.4, but the bicarb on the chemistry will be low, and there'll be an anion gap metabolic acidosis. That's the mixed picture that every emergency physician has to learn before they go do their board exam. There are some complications with salicylic acid that I'll cover in a little bit. But the most common manifestations are CNS, gastrointestinal, of course you can bleed, and you can have tinnitus. There's also occasionally people that present with a non-cardiogenic pulmonary edema. We call that salicylate-induced pulmonary edema. It's not heart failure, it's like ARDS, and it's not known why it happens. So I wouldn't really necessarily rely on these predictive factors that I'm listed on the slide. But be careful, if you start seeing hypoxemia, pulmonary infiltrates, that's salicylate-induced pulmonary edema, an indication for dialysis. Now, we have to get a salicylic acid level to confirm the exposure and to see how severe it is. Now, unfortunately, this test is not available in many parts of the world. Some countries use the ferric chloride assay, which is unfortunately not sensitive or specific enough. So for us in the US, we are fortunate to use serum salicylic acid, which is cheap and easy to get. And we kind of get it to almost all patients, just because, you know, most patients will potentially not be able to tell us a real story or a good story, or the history may not be reliable. They may be tachypneic or tachycardic for some other reason. So we just screen for it. In the past, we used to use a dome nomogram, but this is even before I became a toxicology fellow in 2005. This is an old practice that we don't need to waste time on. It's no longer being used. And the treatment is the most important. For treatment, the first thing you do is think about charcoal. Yes, salicylic acid binds charcoal. So if you have an acute overdose, it's worth doing. If you have an enterohepatic, if you have an enteric preparation, some salicylic acid preparations are enteric coated. Those can benefit from a couple of doses of charcoal. And there's some evidence that shows that multi-dose activated charcoal can help with salicylic acid poisoning. Beyond that, the main focus is going to be urinary alkalinization. Like I said to you, a small percent of salicylic acid is excreted in the kidney already unchanged. What we do is we go ahead and make the pH of the urine very high, like 8 alkaline. Salicylic acid has a pKa of 5. And at pH equals pKa, 50% of the salicylic acid will be present in the anion form of the salicylic anion that you see here in red. As you push the pH higher, more of the salicylic acid will be in this anion form. And will be stuck in the urine and will not be reabsorbed. In the urine, ionized salicylic acid form is reabsorbable. But what you do is you make it an anion by creating an alkaline milieu that makes the acid dissociate into an H+ and an anion. And you trap the anion in the urine. I'm sorry if I'm taking you back to med school, but this is what toxicologists do. We also, in this case, rely on the diffusion gradient. The diffusion gradient helps you as well, as long as you're keeping the salicylic anion concentration high in the urine and the salicylic acid concentration low. There will be a diffusion gradient of the salicylic acid from the serum to the urine. It keeps dumping into the urine and getting stuck there. And that's how you really improve the excretion of salicylic acid in an alkaline urine by urinary alkalization. Now remember, to do this, you have to give enough bicarbonate to make the urine pH 8. And most people don't, unfortunately, check the urine pH carefully. So you have to continue checking the urine pH to make sure you've met your goal. And also you have to make sure that you have a potassium of 4 milliequivalents per liter in the serum in order to avoid acidifying the urine. Because if your body sees that you're hypokalemic, what they do is they reabsorb potassium from the urine. And when they reabsorb potassium from the urine, they excrete hydrogen ion, acidifying the urine, counteracting your effort. So what do? You make sure your serum potassium is 4 and you give bicarb. And often you have to give bicarb as well in the IV. You have to give potassium IV to make sure your serum potassium is 4. How much bicarb you give? A good way to do it is 3 ampoules of sodium bicarb in 1 liter of D5 water. And you run it at 150 to 200 mL per hour. And you adjust based on the urine pH. And you keep checking the pH and the potassium. And you do that until you get the salicylic acid level below toxic levels, say below 30 milligram per deciliter. Another thing you can do also is dialyze patients. And dialysis is very important because some people cannot tolerate 200 mLs of sodium bicarb per hour. They may have congestive heart failure. They may have salicylate-induced pulmonary edema. You cannot give them so much fluid. In these cases, you have to think about dialysis. They may have renal failure. Remember, salicylic acid can cause renal failure. So you have to be careful with these patients. If somebody is already altered or having seizures, you don't have time to waste by giving bicarb. You have to act quickly because the salicylic acid is in the brain. And when the salicylic acid goes into it, shifts the salicylic acid more into the brain and makes you die. So that's why in these cases, you go for dialysis. Some people present with severe acidosis with a pH of 7. In these cases, dialysis is the answer, not bicarb. And even the level of 80 to 100 milligram per deciliter are by themselves an indication for dialysis. So again, hemodialysis is really the definitive treatment. Bicarbonate can be in many ways a temporizing measure. One final pearl or one final warning for you. I've seen few cases in my career where the patient dies right after you intubate them. Like a DKA patient, you try to avoid intubation because these people are breathing fast to keep up with their acidosis. They try to blow off the acid by hyperventilating. If you come and intubate them, paralyze them, and let's say, for example, for God forbid, you cannot intubate them for 5 minutes or 2 minutes. You have to do a bougie. You have to change. You have to bag them. Then you may not keep up with their acidosis. And then when you have acidosis, salicylic acid moves from the urine to the tissue to the brain and causes seizures and arrhythmias and death. So I've seen 2 or 3 cases where right after the patient was intubated, they have a sudden cardiac arrest. If you intubate a salicylic acid patient, make sure that you hyperventilate and closely, rapidly monitor the pH to make sure they don't fall into that complication. A couple of other factoids about salicylic acid. One is that it can also inhibit vitamin K metabolism and causes elevation in the PT-INR. So you may check an INR and see it's elevated. It's from the salicylic acid, and it's treated with vitamin K. Remember, salicylic acid can cause GI bleeds as well, of course. So checking for a GI bleed, being aware that it can cause it, is also important. And I think that's all I have, and we have some time for questions. Thank you.
Thank you, Dr. Kazzi. That was really succinct and very, very well put in the time you had. So thank you so much for that. I've certainly had some cases of salicylate poisoning as well as DKA, and they're very complicated intubation, and try to avoid as much as possible. That's really important. But if you have to do it, make sure you're matching their rate. Really important. Does anyone have questions for Dr. Kazzi? You can unmute and ask, or you can type on the chat as well.
While they do that, Ramu, do you have salicylic acid levels in Nepal?
Actually, that's a really good question for our spies here. Apeksha, Anup, do you know answer on this? Are we able to easily get salicylate levels? Or Rajesh?
I don't think we have in teaching hospital, but maybe some private labs may have it, but we haven't used it so far.
But it certainly is not widely available.
No, it's not available widely.
Outside of the valley.
What about acetaminophen?
We have acetaminophen.
I think it's worth looking at this. I think, to try to get these levels. These are useful levels. We were recently at a meeting at the North American Congress of Clinical Toxicology. Thought that was a good idea, so I hope we can talk to them about this more. Also, want to remind people that in the US, we do almost universal screening for acetaminophen because it's such an asymptomatic overdose. For salicylic acid, you don't have to do it on every patient because usually salicylic acid, they are symptomatic, but the symptoms can be subtle. So if somebody has alto-mental status, tachypnea, tachycardia, if they have an anion gap acidosis, or they complain of tinnitus or hearing problems, in these cases, you should screen for it. So unlike acetaminophen, it doesn't have to be a universal screening, but we often do it because it's cheap, and most of our patients are tachypneic and tachycardic to start with. So we lose that exclusion criteria. So
right, yeah, we have a high, there is high use of salicylates in Nepal, but yeah, these sort of the easy screening techniques or easy labs are not quite available. Most people actually.
And also,
go ahead, Dr. Kazzi.
Sorry, I was gonna say, I forgot to mention something, that also there's this some reports about hypoglycemia in the CNS. I think it's called neuroglycopenia that is induced by salicylic acid. So some people recommend giving glucose infusions to these patients.
Right.
Because they feel that the CNS glucose levels will be lower than the serum. That's kind of the theory behind it.
All right. Does anyone here have any thoughts on this or questions? If not, that's okay. If you do, please make sure to ask while you prepare your question. Again, I shared this earlier in our webinar today, but I wanted to share again that we have next month, we have a very special sort of presentation that is done at the WHO in collaboration with Menatox, as well as the Oman Poison Control group there, along with the Nepal Poison Center. So we'll be talking about lead poisoning. As you all know, lead is a huge public health burden in Nepal, and there's a huge international push to work more on lead, and we're also trying to work on lead from the Poison Information Center. So this would be a really great webinar for you to join. It's going to be on 21st of October, and Dr. Kazzi and myself will be leading this, and we'll have speakers, international speakers, and speakers from Nepal as well in there. I don't know. Can you see this slide? Can you see this here? This information here?
Yeah, we see it. It's important to also remind people that we are going to make this case-based. So I'm already working with Dr. Karel on the program, but I think I would definitely gonna have a typical childhood poisoning case. I think we should also include a gunshot victim with a retained bullet fragment. I have Dr. Randy Smith from the Grady trauma surgery. She's an expert in this as well. We're going to talk about the retained bullet fragments for countries that have its high incidence of gunshot wounds. We'll talk about the children, maybe the pregnant woman that's has an elevated blood level, lead in spices, lead in paint. It's going to be a nice, please be ready to stay for 2 hours. It's not going to be like a quick, we're going to do 2 hours that people can come in and out and we'll record it. So we're going to take our time on this important.
Right. Thank you, Dr. Kazzi, for that. So, okay, we're right on time. I'm so glad. I do want to say before we invite our professor in the clinical pharmacology department to give a vote of thanks to our speakers, I want to say normally we get 200, 300 people for this webinar. And unfortunately, over the last 2 days, we know there is a big disaster that's happening in our country. There's huge flooding and a lot of people dying and in a lot of destruction. So, of course, we are all saddened by this. And despite those circumstances, for all of you joining, it shows your commitment to learning. So we're really appreciative of this, and we have to continue to make our system better. So thank you. With that, I want to invite Dr. Sangaratna Bajracharya, who is a professor in the clinical pharmacology department, who is, as you all know, is the implementer of this Poison Information Center and has been an amazing partner and has done such a great job over the last year. So I'd like to invite Dr. Sangaratna to give a vote of thanks. Thank you.
Thank you, Dr. Ramu. It was really wonderful time to hear both the speakers. First, Dr. Grant Comstock. So he has very nicely, summed up various toxidromes, ranging from serotonin syndrome to cholinergic poisoning and also anticholinergic poisoning. And it was nice that he started with, shed to learn context with MCQs, and he tried to explain with various triangles of syndromes for the easy recalling. And it was so nice to hear from him very self-explanatory 5 scenarios within short period of time. Thank you so much, Dr. Grant Comstock. So it was very nice to hear, and definitely I'm very happy to listen to Dr. Ziad Kazzi, sir. So we are also very, in depth with sir for training our spies. So it was very nice time hearing from you, and it was very, not only presentation, but some of the important aspects related to salicylate poisoning, like where it initially has, alkalosis, respiratory alkalosis because of hyperventilation. Later on, it goes to metabolic acidosis. So during treatment, sometimes we tend to, get confused in those aspects. And it was very, nice to have you around in all the presentations and guiding the activity of Poison Information Center. Thank you so much, sir. And we would also like to hear you in days to come and in the next session itself related to lead poisoning, which is one of the, burning issues nowadays, not only in Nepal, everywhere, with use of even lead containing substance, including disposal of lead acids, etc., etc. So thank you so much, sir. And I also thank Dr. Ramu, who is always active and who has always initiated for various activities of PIC. He was there from the beginning of this concept of our PIC, and we are very happy to have you here with coordinating, all the CMEs. And I also thank all the participants. Although, as Dr. Ramu has already said, we used to have even 200 plus participants, but today it's less. But we are a group of people who are very interested in poisoning. So thank you all. So would like to see you again. Thank you so much.
Thank you.
Thank you so much, and see you all next month. And this will be on YouTube in like next few hours. So thank you all. Thank you, Dr. Kazzi, Dr. Grant, and Dr. Sangaratna.
Thank you so much.
Okay.
Thanks,
Bye,
everybody.
end the meeting now.